Yes, sir. Thank you, sir.
Education has been changed and trends of management also has been changed. So how? So epilepsy, you know that there is, of course, in ancient Indian civilization, this age of Charak, Sushrut, they also knowing epilepsy. But somehow Indian research are nowadays lacking in epilepsy. So whatever development was in that era, 2000 years back, subsequently there was no development in Ayurveda and others to manage epilepsy. So what we are following the definition, classification and management, what the International League Against Epilepsy is providing to us. So I will speak on the light or on the pathways where what International League Against Epilepsy, ILAE, has suggested. And in fact, we are practicing on the ILAE guidelines. So let's see the classification first, and then what will be the modern classification and how the change has been done. What is the change of scenario? So out of those 3 million, 1 million people are potential candidate for epilepsy surgery. So that is the modern development. So epilepsy is not a disease which is non-curable. It can be cured. There are certain aspects, but I will show in a couple of slides. If it is diagnosed properly, if it is managed properly, of course pharmacotherapy is the mainstay of management. So first definition, what was suggested by ILAE in 2004, that at least 2 unprovoked seizures. ILAE has included reflex seizure. There is no development in Ayurveda. So there are Ayurvedic hospitals the government is planning to launch, but there is no development. In news, there is subtle changes, not much changes, that syndrome has been added and epilepsy. During eating, patient gets seizure. So eating is no burden on the treating physician, that is very important. And we can clarify the patient what is the risk of seizure in subsequent period. Quickly going a couple of cases, so you can judge what is the situation. A 40-year-old man, they collapsed on the street. I with a recurrent seizure for last 2 days, no prior history of fever, birth trauma, family history, irregular seizure for last couple of years, taking AEDs from their family physician, recurrent seizure, young boy. There's certain MRI findings, certain CT finding, and certain findings. What are those findings? I think Dr. Khanna can recognize very well from distance. 4 hours apart, EEG showing abnormality, frontoparietal region, subtle MRI findings, T2 hyper, left cerebral artery territory stroke, now presented with unprovoked seizure. 2 months back, stroke happened 2 months back, now presented is the disease, where there is a tendency of the brain to this epilepsy. I told that they are basically provoked seizure, but ILAE has included those groups inside the heading epilepsy. So diagnostic confirmation, you have to get an EEG. Of course, history is very important. History is the mandatory part. EEG, you can localize where is the seizure focus. Digital EEG is preferable. You can increase the channel starting from 32 to 64 channel digital recording you can give. You can do video EEG with suspicion that it is not true seizures, can have a small hematoma inside, intracerebral hematoma. So you can get a CT in emergency situation, but otherwise as a routine, pseudo seizure, syncope, sleep disorder, and cardiac arrhythmias, emotional outburst. Good number of studies. This is a huge study published in New England Journal of Medicine, NEJM. The chance of recurrence in 60 months after epilepsy is if he crosses that age. For example, absence seizure. If person crosses that age, 14 years, if he crosses 14 years, that you know that generalized seizure partial seizure, again divided into many groups. So that was the old classification. Then again a classification came into in between, that was very. So this is the simple old classification. Either follow that old classification or switch on to new classification. That was the old classification. Simple.
Quickly.
Conclusion. So new classification. So new classification was launched in April 2017. So this is the defined epilepsy and non-epileptic seizure. So I am just quickly going through. So that case was acute symptomatic seizure, alcohol withdrawal seizure with delirium tremens. You know that after unprovoked seizure, then chance of recurrence is not that high. Somehow that you have seen unprovoked, though it was unprovoked, but as because there is a gap definition more than 24 hours apart. So after 6 weeks of stroke, so again that boy, that was case of focal cortical dysplasia. So that boy is epileptic, 2 seizures, MRI find. So this is important. This not for this platform to discuss. There are certain congenital and focal cortical dysplasias, etc. Fascinating condition, immune-mediated epilepsy. And management, pharmacotherapy is the mainstay. So newer things, just I will highlight, newer things is the newer drugs. Newer anti-epileptic drugs are in the market. You see the old drugs, how there is evaluation of the drug. Professor Parle can tell you in detail. So after 2010, so I was talking about some surgical treatment, and I told that therapeutic triage in epilepsy care. So it is a little tough, we are not going to discuss. And pharmacotherapy, single drug, monotherapy, so always better means that you should consider first. If there is failure of one drug, you can think of another drug, or 2 drugs are exhausted, then you can think. So what is the rationality of polytherapy? When to combine? If patient tolerates the first or second drug well, with useful but suboptimal response, this is very important, then you should consider combination. So there is a huge article published in Neurology. See, the more drug, this is just another topic, I'm not going into that, it's not the platform. And AN and American Academy of Neurology guidelines are there. So quickly, 25-year-old woman, 2 unprovoked seizure, 1 year apart, epilepsy, yes. Photic convulsion, I told that reflex epilepsy has been now included by ILAE. So it is seizure. Benign Rolandic epilepsy, I told, unobserved episodes over 6 months, consisting of fear, difficulty talking, need to walk around, or new development. But classification wise, we can label it as unknown group, because both definition of epilepsy require confidence that the person has had at least 1 seizure rather than the in new definition. It may not be so good because it may upset those diagnosed sooner, may increase properly this topic. So we will highlight on that. So only a couple of questions quickly.
Thank you.
There is an overlap between occipital lobe epilepsy and migraine. Photosensitive epilepsy, I told, that can have overlap with migraine, and this vertiginous migraine, vertigo associated migraine, vertiginous migraine, MAP. Yeah. We should rule out that's the.
You see that you have also signed your attendance. Only those who attend the sessions who sign in the attendance.
It's a pleasure to interact with such august gathering. When God and nature, with man with Martian characters, strong physique, suited for evolution, whereas Eve, a female, with Venetian characters, with typical physical characters and life cycle suited for certain purposes in life. Times have gone, however, the man and female equality has become the issue of modern times. However, health-related issues remain different in both the sexes, pertaining to the typical life cycle of women under hormonal influences. So the neurological disorders are also different in other sexes. Today I am going to discuss headache, which is a very common topic in neurology. Almost 90% people have headache at some time or other in their lifespan, and females are more predisposed to headache. Headache can be an innocent disorder, however, at times it can be quite troublesome. Aspect of woman and man's brain. What are the basic differences? The anatomical difference between a woman and man's brain is that the volume is larger in male brain. It's almost more than 10% of female brain, whereas in females, the volume of brain is relatively smaller. As far as dominance is concerned, in male, left brain is dominant, whereas in female, it is evenly balanced between left and right, though processing is more intuitive in females. Mathematical skills, they are better in males in view of better developed inferior parietal lobule, whereas in females, inferior parietal lobule is less developed. Coming to language. Language is larger area in females, so it is better developed. However, it is less developed in males, so the females have better communication skills, as we all know. Then coming to spatial orientation, males can perform better in spatial tasks. However, in females, the parietal lobe is a bit thicker, so they have difficulty in performing spatial tasks. Then size of hippocampus. Females are more emotional, they have larger hippocampus, whereas males have smaller hippocampus. So basic is that the gonadal hormones and genes on the sex chromosomes, they influence neuritic outgrowth, dendritic branching, myelination, synaptogenesis, and neural plasticity. To our surprise, the brain represents the important target for estrogen and progesterone effects by virtue of having high density of estrogen and progesterone receptors in amygdala, hippocampus, and hypothalamus. Coming to headache. Demographical aspects say that headache affects almost 90% of the general population, and out of which primary headaches are 90% and secondary headaches are 10%. WHO also ranked headache among 10 most disabling conditions in both the genders, and it is 5 most disabling conditions among women. It affects 18% of women and 6% of men, and the lifetime incidence female versus male is 43:18. So what are the types of headaches in females? The primary headaches are basically migraine, tension type headache, trigeminal autonomic cephalalgia, chronic daily headache, new daily persistent headache, primary thunderclap headache. I think these terms you are not much aware, but let's just have a look into this. Idiopathic stabbing headache, nummular headache, and hypnic headache. And the secondary headaches where we need urgent attention are 10%, and these are medication overuse headache, idiopathic intracranial hypertension, secondary thunderclap headache, headache secondary to PRES and RCVS, headache secondary to cerebral venous thrombosis, and lastly but important, post-LP headache following caesarean section. Headache is predominantly a female disorder, as I have told you. There is no gender predilection till menarche. However, 50% women suffer from menstrual migraine. Onset is at menarche. There is exacerbation during menstruation. Headache fluctuates in intensity during perimenopausal period. However, after menopause, there is a period of quiescence. Pregnancy and lactation, of course, is a period when you are free from headache relatively, owing to the hormonal influences. And lastly, hormones and contraceptive pills also are precipitating agents for migraine at times. This is the typical diagrammatic representation of the menstrual cycle in female. It shows all hormonal fluctuations, estrogen, progesterone, FSH, and LH. Basically, it is the fluctuating level of estrogen at the time of ovulation and just before menstruation that precipitates migraine. Secondly, imbalance of estrogen and progesterone also precipitates migraine. What does estrogen and progesterone do? Estrogen induces influences cerebral excitability through release of nitrous oxide. The peak estrogen levels, they are associated with decreased serum magnesium, and this facilitates NMDA channel opening. Estrogen also facilitates glutaminergic system, which is an excitatory system in the brain, whereas progesterone has opposite effects. It induces vasomotor smooth muscle relaxation, and it influences, in contrast to NMDA and glutaminergic system, it influences GABAergic system, and thereby it suppresses neuronal activity. Coming to pathogenesis of migraine in female, as I told, estrogen withdrawal is a trigger for migraine. Ovarian steroids cross blood-brain barrier. They affect several pain processing networks in the brain. They modulate hypothalamic beta endorphin, dopamine, beta adrenergic, and serotonergic receptors. There is decrease in the central opioid tone under the effect of estrogen, and this increases cerebrovascular reactivity to serotonin. It also decreases dopamine receptor hypersensitivity. All these things lead to precipitation of migraine in females at times when these hormonal fluctuations occur. Pregnancy is a period from 6 weeks to 3rd trimester when estrogen levels are very high. So females are protected from migraine during this period, whereas females may have migraines in 1st trimester of their pregnancy. Coming to menarche, menstruation and migraine. The migraine has its onset at menarche. It shows exacerbation during menstruation. There are two types of migraine related to menstrual cycle. One is menstrually related migraine, another is pure menstrual migraine. Menstrually related migraine is which occurs on or before 2 days to plus 3 days of menstrual cycle, with additional attacks of migraine at other times of cycle. Whereas pure menstrual migraine only occurs before 2 days or after 3 days of onset of menstrual cycle, and there is no additional attack at other time of the cycle. Menstrually related migraine is associated with or without aura, whereas pure menstrual migraine never has an aura. Pure menstrual migraine is more common in comparison to menstrually related migraine. So in females, menstruation is an important precipitating event for migraine, precipitation. What are the differences between menstrual? We come across both types of migraine, menstrual migraine as well as non-menstrual migraine. So what are the differences between the two? The menstrual migraine is often more debilitating, it lasts longer, there are more chances of recurrence. Aura is not common in menstrual migraine, it is less associated with nausea, vomiting, and responds poorly to acute treatment. Whereas non-menstrual migraine is less debilitating, we see it very often, it lasts shorter, it responds to treatment, may or may not recur, or aura may or may not be there. They are associated with nausea and vomiting also. Coming to pregnancy, as I told you, pregnancy has variable effects on migraine. The migraine symptoms may increase, decrease, or they become static. Females with menstrual migraine may have relief during pregnancy. Some have first attack of migraine during 1st trimester that gradually subsides in 2nd and 3rd trimester. Postpartum period, there is sudden fall in estrogen level, and more than 50% female experience severe attack of migraine in immediate postpartum period when hormonal fluctuations are going on. So, the women with migraine are also at high risk for gestational hypertension, preeclampsia, and vascular complications of pregnancy like ischemic stroke, more so when migraine is associated with aura. Well, we should not forget about secondary headaches. I know that more than 90% headaches are primary headache, but almost 10% headache are secondary headaches also because of some or the other reason. So we should not forget secondary headaches while evaluating a case of headache in females or during pregnancy. And other catastrophic causes of headache during pregnancy may be cortical venous thrombosis, that is occlusion of veins in the brain, subarachnoid hemorrhage, reversible cerebral vasoconstriction syndrome, I am going to tell about this later, and arterial dissection. Last but not the least, following cesarean section post LP headache should not be forgotten. All these types of headache needs to be excluded before diagnosing a headache as a case of primary headache or migraine. Perimenopause, menopause and migraine. Prevalence of migraine during menopause is 10 to 29%. There is great fluctuations of hormonal levels in perimenopause that gradually becomes becomes stable in menopause. Exacerbation of symptoms in perimenopause ameliorates during menopause. The natural menopause is associated with lower symptoms than the surgical menopause. Coming to oral contraceptive pills and its relation with migraine. Oral contraceptive pills overall increases risk of strokes in migraine. OCPs have controversial relationship with migraine. They may precipitate or may they change the pattern of migraine in some cases. There may be no change in 39 to 65% cases. However, some cases might improve and some cases might exacerbate during intake of OCP. Out of two types of OCP, that is combined oral contraceptive pills and progesterone only pills, I think progesterone only pills are safer in women with migraine with aura, and especially third generation progesterone like desogestrel, gestodine and norgestimate. They maintain stable estrogen level and they have positive influence on nociceptive threshold in migraineurs. Whereas combined oral contraceptive pills may induce de novo migraine. They may worsen migraine with aura, and COC may induce deep venous thrombosis, arterial thrombosis and ischemic stroke also. Its use is discouraged in females above 35 years of age, smokers, obese, when there is family history of cerebrovascular accident or history of hypertension and dyslipidemia. WHO also says that migraine with aura is an absolute contraindication for the use of oral contraceptive pills. Coming to hormone replacement therapy and migraine. Hormone replacement therapy may have variable effects. There may be complete remission of migraine. Sometimes it is used for treatment of migraine, and there are 64% patient may have complete remission. However, in 22% there may be no change and there may be worsening of migraine in 13%. So effect of estrogen fluctuation on migraine in perimenopausal woman can be attenuated by HRT in general, that is class 2 evidence. A woman whose migraine worsens with menopause has migraine worsening with HRT also. Migraine with aura worsens with hormone replacement therapy. HRT is associated with increased risk of vascular disease, endometrial and breast cancer, that is class 1 evidence. So decision should be taken on risk benefit ratio. HRTs that can be used in migraine patients are estradiol, lowest effective dose, non-oral route, and the transdermal route, safer for cardiovascular risk. If aura starts for the first time after starting HRT, dose of estrogen should be reduced. Whereas progestins, levonorgestrel, intrauterine system, medroxyprogesterone and drospiridone may be safer options. Tibolone. Tibolone is a 7-alpha-methyl norethyldiethyl, a synthetic steroid drug with estrogenic, progesterogenic and weak androgenic property. It can be safely used for HRT in doses of 2.5 mg per day. Coming to treatment issues in women with migraine. Since till now we have discussed various aspects of migraine and its precipitation, now let's come on to the treatment aspect. The menstrual migraine symptomatic treatment can be done with help of triptans and then prostaglandin synthesis inhibitors and ergot alkaloids. Whereas for prophylaxis, triptans can be combined with oral contraceptive pills in doses I have told you, NSAIDs, vitamin E, GnRH analogs, dopamine agonist and magnesium. Migraine in pregnancy should be treated conservatively. The mild headache can be tackled by lifestyle modification, relaxation techniques, avoidance of precipitating factors and good sleep. Patient not responding to above measures, then the physician should discuss risk-benefit ratio with the patient before initiating treatment. However, if any drug has to be used, then acetaminophen has minimal side effects on fetus and it can be used safely. NSAIDs, narcotics, brufen, triptans and ergots are contraindicated for migraine in pregnancy. If headache is intractable, then you can use very low dose beta blockers or tricyclic antidepressants after discussing the risk-benefit ratio. What is the treatment for menopausal migraine? It's of course non-pharmacological first, like relaxation techniques, biofeedback, cognitive and behavioral therapy. Milder symptoms can be tackled with isoflavones. However, if the symptoms are severe, then HRT can be used, non-oral route, transdermal and lowest dose. When estrogen is contraindicated, SSRI like venlafaxine, fluoxetine and what is the relation of migraine, epilepsy and and sex hormones, as somebody was asking. I would like to tell that migraine and epilepsy in females can be under the effect of estrogen. Estrogen may increase susceptibility to migraine with aura. On the other hand, estrogen also increases cortical excitability and may increase seizure susceptibility by decreasing after discharge threshold and facilitate kindling. That is a common incriminating factor for catamenial epilepsy. That is epilepsy, women, hormone and overall cardiovascular risk. Let's have a look at it. Females with migraine have increased risk of strokes, myocardial infarction, intracerebral hemorrhage and renal vasculopathy as compared to females without migraine or males with or without migraine. Migraine with aura, use of OCP, smoking, genetic predisposition in migraine patient further increases the risk. Migraine, the benign disorder. Commonly we think that migraine is a common disorder and it's not something to worry. But to my utter surprise, when I looked into literature, I came to know that migraine disorder is associated with increased risk of ischemic stroke and sites. One is migraine, another in neurology is idiopathic intracranial hypertension.
Confusing chapter, but I face few patients, but I am a psychiatrist.
Yeah.
I treat sexuality, and what common side effect every patient taking sildenafil is a very common side effect of sildenafil headache.
Yeah.
How to treat that? Whether can we prevent it or given tablet along with sildenafil, or after taking sildenafil, how to cure headache of those patients?
Well, I have also seen 1 to 2 cases of severe headache after use of this drug, but I don't think there is any specific medicine for this. Only thing is that sometimes you may have calcium channel blockers as prophylactic agent for these types of headache. And a person reported headache after using this drug.
For everybody using sildenafil gets headache, almost 90%.
Yeah, there is no specific drug other than calcium channel blockers because I also looked into literature after I saw that case.
There's nothing to prevent it.
Calcium channel blockers, I am telling you.
For prevention.
Yeah.
Overuse headache. They keep on taking medicines, no relief.
Yeah.
Then we
That I told that if a person is having headache or like using triptans or NSAIDs for more than 15 days every month for 3 months, and if the headache is still refractory, does not respond, then you should think about medication overuse headache. And first thing you do is that you stop NSAIDs, give prophylactic agent, and manage conservatively by I think biofeedback techniques and sleep hygiene, as I told. You have to stop NSAIDs immediately.
Those are psychogenic TTH or they are having some different pathogenesis?
They have different pathogenesis. There is increase in the excitability of trigeminal nociceptor pathways in medication overuse headache. So they are not psychogenic, basically they are organic, but you have to treat them accordingly and stop NSAIDs in all such cases. I am not a sleep hygiene specialist, but what I think is that 7 hours sleep every day, and before sleep you have to what should I say?
Sleep hygiene, I mean, you have to keep your bedroom very neat and clean. Don't
Dim
take
light, dim light,
dim light, don't take any stimulant, tea, coffee.
comfortable clothing while sleeping, and then 7 hours sleep. And
Sleep disorder. Listen, huge chapter. It's just sleep society.
but basically, crux is that you have to like the bedroom should be quite comfortable to you. You should not change the place frequently, and then light should be dim. And you should ideally you should take a glass of milk or take bath before sleeping. The clothing should be comfortable, and then 7 hours sleep is required every day. And 45 minutes nap.
When a lady is not happy with her mother-in-law or husband or the wife, it's a very important factor, you see. This is, in fact, when she is maligning, and every doctor will fail to diagnose. How will you diagnose such headache? Thank you.
Yeah.
No, this is a burning question of the society. Although you are a female, but this is a very important question felt in every home. And we are at loss to find out a solution. If you have got any, please tell.
We have a project, sleep disorders, and every headache is a result of some kind of abnormality taking place inside. It could be a physical injury, it could be an emotional injury. So what you are talking
It's all
about is
hormonal interplay actually.
it's hormonal interplay, and those hormones which are involved in the normal sleep pattern, non-REM, REM, if that can be streamlined, then this headache would be over. But the solution is not the drug. The solution is in the hands of mother-in-law and the daughter-in-law. You know, how long you keep taking the drugs.
Migraine is a neurological disorder or is it muscular disorder?
Migraine is a neurological disorder.
Ma'am,
Costly treatment so frequently.
You have used Botox?
No.
Huh?
No.
So have you used something one patient that was really intractable?
There are people who are using Botox in headache, but till date I have not used it in headache.
जी सर प्लीज मैम सर प्लीज
topic, which is a very current addition to the management of acute ischemic strokes. Now, you all know that the holistic approach to the management of acute ischemic strokes has become a very positive approach to the last, except the stroke unit or aspect. And the controversial role of heparins, whether conventional or low, for malignant infarction is not known from today. The first trial was done in 1996-7 from Germany. After that, lot has evolved, and now we have for malignant MCA infarction. I'll tell you what I mean by malignant. MCA is middle cerebral artery. It is not an infarct only in the distribution of the middle cerebral artery. It could be the posterior cerebral artery. It could be the anterior cerebral artery. But most of these infarcts, which evolve over a period of time, are the middle cerebral artery infarcts. So now we have evolved with a large number of trials which I'll take you through to stress upon the role of following up a patient, acute patient of an MCA infarction in a well-trained ICU, and you would see that 10 to 20% of them would convert into a malignant MCA infarction. With this case, because this is one of the best cases which I have had. This was a 75-year-old Canadian individual who was admitted in Agra, and he came for a trip to see the Taj Mahal. He presented there with an acute onset of left side hemiparesis on the 4th and was managed elsewhere with the conventional treatment for an MCA infarct. He was admitted to our hospital with the progression of symptoms, and you could very clearly see the whole black area on the right side of the brain was a huge area of infarction. We had no choice, as the patient was progressively deteriorating. When he was referred to us, he was a drowsy patient. By the time he came to us, he was becoming more drowsy. Pupils started dilating. So he had a typical MCA infarction. He had a hemiconnectomy done, and if you see here, the patient improved significantly, and he had become conscious and was discharged. So this is another patient again, which is you can see more clearly, a large area of MCA infarction. Now, you all know, and I'm quite happy, that there's so many good ICUs coming up in Haryana. So one at Bhawna, then I've been for a talk to Karnan, and now here, that there are a group of infarctions in spite of your giving them excellent care. And you know the medical methods of decreasing intracranial pressure. You know that an infarction produces, when it comes, a cytotoxic edema, and then it gets converted into a vasogenic edema. And it is this vasogenic edema which produces the large amount of pressure effects. So any ICU, you admit a patient, you give him mannitol, you put him on a ventilator, you give him oxygen therapy, you ventilate him, still he continues to deteriorate. So this is what is a malignant MCA infarction, a deterioration of the neurological deficit. Now while I just 2 is slight disability, 3 is moderate disability, 4 is moderately severe disability, 5 is severe disability, and 6 is death. So whatever we talk now, by doing hemiconectomy, what do you achieve? Do you achieve a modified Rankin of 3 or even before, or more than that? Or do you get a modified Rankin of 4 and below? So you don't want to have a modified Rankin of a scale 4 and say the hemiconectomy and the patient did very well, so I'm very happy. The first study of removing the large areas of infarction, which is called hemiconectomy in large MCA infarctions, was first published by D. Edrist. It was an abstract. 5% had an MRS of 5, bad. 40% had an MRS of 4. 38% has an MRS of 3. So overall, if you look at these trials, fantastic. The mortality came down and the quality of life of the patient discharged was 38% of these had MRS of 3 and 17% had an MRS of 2, which meant that these people were absolutely independent. What a fantastic result. The statistical analysis showed that the MRS of less than 3 was 43% in surgical group and 21% in medical group. Again, fantastic. Now, the Dutch Hamlet trial, which was a prospective trial, which took in about 64 patients, 18 to 60, MCA infarction, 2/3 of the territory, 200 cc, NIHS scale about 16 in non-dominant and 21 in dominant hemisphere. So they had a larger number of patients who were in dominant hemisphere infarct. And we all know that dominant MCA infarcts do worse than non-dominant MCA infarction. The mortality again from 59% to 22%, and 1 year follow-up, MRS 5 in 24%, 40% MRS 4, 28 MRS of 3, and 4% had MRS of 4. No difference was found in the functional outcome between the medical groups and the surgical group if they have their trial. Again, when there was such a discrepancy, there was a big Chinese trial. Obviously, you know, we associate ourselves more with the Asian trials, China or Japan. None of them come out from our country. I think till now we don't have. Dr. Burman would agree with me. At any trial, where so much of work has been done in hemiconectomy in the world all over, they randomized again 47 patients, 18 to 80 years, 2/3 of the infarction, 200 cc, more than 50% of patients aged 60 years, surgically done within 48 hours of onset, significant reduction of mortality again from 60.9% to 12.5%, no significant difference between the surgical group and the medical group. At 1 year follow-up, 5%, 15% had an MRS of 5 and 10% had an MRS of 2. These results were significantly worse than the overall outcome. So this study also did not contribute much to that. This was one of the latest trials, which is a German Destiny trial, which had a large number of patients of 112, more than 68, more than 60, age 17, MCA infarction 2/3, NIHS 14, then 19, within 48 hours, mortality again came from 76 to 43% at 1 year follow-up, and less than 10% had MRS of 3, and they had severe depression associated with this. So, what do you make out of this? No doubt about that fact. What do you make out of the positive trials and not very negative trials? You do make out one thing, that hemicraniectomy has a role, but in a very select group of patients. You should not do hemicraniectomies for patients above the age of 60 years, which I don't. Till the time you are a very good patient with no comorbid conditions, then you would consider. And obviously, you try to avoid doing in patients who have higher NHS scores. And we have certainly shown that the mortality is going to definitely come down, but morbidity may or may not significantly improve. Only good reason to doubt hemicraniectomy in malignant infarct is the increase of patients with severe disability. 1. 2. Given the randomized controlled trial data, the only reason to doubt hemicraniectomy in malignant MCA infarct is an increased patient with MRS4. So if you are going to have save a patient, give her nothing but give a vegetable to the society, are you justifiable in doing such a procedure? Now, very interesting, very thought-provoking things. Hemicraniectomy, RCT defined one step in defining optimal treatment. So we've opened a new course, a new avenue for stroke patients, because we can now pick up those patients where you decrease the mortality and have a better MR. It is likely that 1 year follow-up is too short to evaluate the outcome. Selection of patients is very important. When I gave this talk, Dr. Burman was there at the Delhi Neurological meeting and also at the meeting of the academy. The same thing was asked there, selection of patients. To identify best candidates. Don't hemicraniectomy for a 70-year-old man with a very high NHS score, with a diabetic, hypertension, but you get nothing out of it, except that you give a vegetable. Hemicraniectomy should not be done above the age of 60. I am very clear about the procedure should be performed early. Early means not as patient walks into your clinic, you say, I'll do hemicraniectomy, but he should be observed carefully in an ICU setting. Observed in the form of his blood pressure, his respiration, his pulse, his pupils, and the surgery should be done before you allow him to coma. Your results are going to be good. That is why the ICU care of our stroke patients is extremely important. It is not only that we put a board outside stroke unit, but it is a totality of treatment of a stroke patient. Good physician, good respiratory, neurology, good physiotherapy, good outcomes you will be able to give. The mortality and morbidity is extremely important. Irrespective of all age, all 3 randomized controlled trials demonstrated the mortality is reduced from 46 to 76% from 11 to 27, which is very good. The morbidity reduction was mixed.